Welcome back, dear audience, and let me present you my progress on my PhD thesis, which is the impact of uterine surgeries on clinical and reproductive health. My name is Lőrincz. I'm a medical doctor and a full-time PhD student at the Department of Obstetrics and Gynecology at Semmelweis University. My supervisors are Ferenc Bánhidi, Márton Vezér, my SMS is Anett Ranc, and my statistician is Mikót Bakony. My vision are women without postoperative complications after uterine surgery, and my mission is to find uterine surgical techniques with the least amount of complications. Right now I have two ongoing projects, which I will talk about in detail. The first one is investigating the efficacy and safety of different cesarean section layering techniques. Cesarean section use continues to rise globally, right now accounting for more than 1 in 5 of all childbirths. If we take a look at the numbers in Europe, this rate is even higher, and it is estimated that by 2030, nearly a third of all births will take place via cesarean section. Cesarean scar defect is an underestimated pathology due to clinicians' unawareness, and it can have many potential complications ranging from infertility to the life-threatening ones like placenta accreta spectrum disorder, placenta previa, scar pregnancy, uterine dehiscence, uterine rupture. Single or double layer closure of the uterus remains a topic of debate because techniques vary from clinic to clinic, from surgeon to surgeon, and clinical outcomes are lacking. Here we can see the different types of single layer and double layer closures, and also our aim, which is to compare the different layering techniques and assess the complications in post-C-section women. Our clinical question is, does double-layer cesarean section closure technique result in a lower incidence of complications compared to single-layer closure? Our population are post-C-section women divided into two categories, women with subsequent pregnancies and women without pregnancies. Our intervention is double-layer closure technique, the comparison is single-layer closure technique, and our outcomes are complications related to the cesarean scar defect itself, and to the maternal infectious morbidity, and to the details of the procedures. We hypothesize that double-layer technique results in an incidence of complications, in a lower incidence of complications compared to single-layer technique. We conducted our systematic search in 3 main databases with the following search key, which resulted in more than 9,000 articles. And after the full text selection, we are left with 32 articles, and the citation chasing gave us an additional 2 articles. Here you can see which outcomes do we want to look at, and we have 2 finished analyses. The first one is a cesarean scar defect at the 6 weeks follow-up, and here you can see that we compared the single-layer technique with the double-layer technique, and this analysis consists of 3 studies, 2 RCTs and 1 cohort study, and contains more than 800 patients. We also did a subgroup analysis. In the subgroups, we included unlocked and locked sutures, and you can see that the overall odds ratio is 1, which is not statistically significant, and we can say that no significant difference between the single and the double layer closure was found. Our second outcome is the cesarean scar defect at longer follow-up from 6 to 24 months. And in this analysis, we also compared the double-layer closure with the single-layer closure. We have 9 studies, 6 RCTs and 3 cohort studies. We have a high heterogeneity due to the fact that only 2 of these studies included only primipara women, and in the rest you can find women with previous vaginal deliveries, and also here is the same, like the odds ratio is 0.73, and we can see that this is not a significant difference between single or double layer closure, although we can see that there are more articles on the more common single layer, on the single layer side, but these are, they have very few patients. Our study has strengths and limitations. We mostly included RCTs, which give the highest level of evidence. We have a high patient number and, of course, our methodology. And our limitation is the high heterogeneity. So in conclusion, there is no difference between the double layer and the single layer closing based on the distinct subgroups, the locked and the unlocked one. And we can say that single layer unlocked sutures should be used because they are more, they take less time in the operating room and are more economical from a suture material usage point of view. And implication for research, we would like to see more RCTs and cohort studies with different subgroups based on parity and the previous cesarean section number. Here is the progress of our first project. We finished the risk of bias assessment for the randomized control studies, and we want to move on with the cohort studies. My second project is comparing pregnancy rate after laparoscopic and open myomectomy. And a little bit about the background. Approximately 70% of women develop 1 or more uterine fibroids by the time they reach the age of 50. Fibroids have been linked to both infertility and recurrent pregnancy loss. Submucosal and intramural fibroids above a certain size are the types that influence fertility the most. Traditionally, surgery for uterine fibroids require open surgery. However, laparoscopic myomectomy can have several advantages like reduced hospital stay, less peritoneal trauma, which result in decreased adhesion formation. Our aim is to compare the safety and efficacy of laparoscopic myomectomy and traditional laparotomy to determine their effect on pregnancy rate and the pregnancy rate after surgery. Our clinical question is, does the laparoscopic myomectomy result in a higher pregnancy rate compared to open myomectomy? Our population are women with fibroids. Our intervention is laparoscopic myomectomy. The comparison is open myomectomy. And the outcome is the rate of pregnancy success after operation. We hypothesize that pregnancy rate after laparoscopic myomectomy is higher than after open myomectomy. Our clinical implication is helping clinicians in the personalized decision making. Here you can see our preliminary search key. The first domain is related to the fibroid. The second one is to the operation itself. And these are our searches. All of our key articles have laparoscopic myomectomy as the intervention, traditional laparotomy as the comparison, and the pregnancy rate as the outcome. So to sum it all up, we have 2 ongoing projects which we would like to submit by May and September of this year. Thank you for your attention. Believe you can, and you're always there. You're halfway there. Thank you.
The result of the first project, the interim results were very interesting to me, and I was wondering on the first forest plot, which was a follow-up of 6 weeks, I believe.
Yes.
There the risk ratio was 1, so there really wasn't any difference between the two techniques. And on the second forest plot with the follow-up time up to 2 years, there still weren't any significant differences, but clearly there was a tendency toward the double layer technique. And my question is, I was wondering what could be the case in a long run, so maybe up to 5 or even more years of follow-up. Maybe the risk ratio could shift more towards the double layer techniques. Were there any articles about this, or what do you think?
So these are the 24 months are the tops in time which we found as a follow-up time. So they haven't looked at like longer follow-up times. I mean, we haven't found studies on that yet. But in my opinion, there shouldn't be any change after 2 years.
Okay, thank you.
Okay, Kincső, thank you very much for your nice presentation. I just have a little short question regarding your first project. Do you know, or do you have any data, there is a connection, is there a connection or correlation with the quality of the sewing material and the successful of these techniques?
Yes, so there are also randomized control trial which look at only the suture material. We didn't want to include that because we already have had our subgroups, and I think, of course, suture material matters, but we haven't looked at those.
Thank you for your presentation. I have one question. Do you think there are specific patients who might benefit more from the single and other patients might need the double?
So we found that in some cases the surgeon, despite the randomization, decides to use a double layer technique in case of hemorrhage, greater hemorrhage. So there might be some cases in which you should stick to the double layer technique.
Yeah, thank you.